In today's episode, we're diving into a critical conversation about the future of our profession with returning guest Ben Galin for part 2 of our discussion. What started as an exploration of the evolving roles of PTAs and COTAs led us to uncover something profound: the pressing need to achieve practitioner status at the federal level. In this episode, we challenge conventional thinking about how we utilize our therapy assistants, explore exciting career pathways in digital health, and most importantly, identify key legislative changes that could truly transform our profession. If you're tired of fighting battles we can't win and ready to focus on meaningful change that will elevate physical therapy, this episode is your call to action. Join us for a candid, eye-opening discussion about where we need to focus our collective energy to create real change in physical therapy. This conversation isn't just about understanding the problems, it's about charting the course forward.
Always.
Hello, everyone, and welcome to episode 9 of the Future Proof PT podcast. I am here with my co-host, Alex Bendersky, our guest who has joined us willingly for a second round, Ben Galin. And today we're going to talk about the role of physical therapist assistants and certified occupational therapy assistants. We're going to talk about our experiences in working with them in the past, all of us being more mature therapists who've had windy careers and a chance to experience different, work environments. And then thinking about what the career ceiling looks like that some therapist assistants talk about, sort of what we think the different options are that maybe they should be thinking about. What kind of different paths have we seen work? So let's start it there. Before we started, Ben, you had brought up something that I think might be great to talk about, and that was how it shouldn't be a cookie cutter way of utilizing therapist assistants in an outpatient setting. So if you want to start, that would be awesome.
Sure. I mean, I've worked alongside therapist assistants since my internships, in the hospital setting, SNF setting, home health setting, outpatient setting. I have worked in some settings where there aren't any for one reason or another, but I'd say majority of the time, yes. And I'd say the pitfall that tends to gotten into where there kind of is are we utilizing PTAs and COTAs correctly, is when no different than a pitfall of 3 times a week for 4 units, as we were discussing in the last time, is this concept of I'm going to operationalize a PTA or COTA where I being some management position says PTs do the evals, PTs do the progress, PTs do the discharge, research, and then I'm going to stick a PTA in between that model because it brings my cost down, which obviously in an outpatient world with a 15% cut, if you do the math, usually actually you're better off not bringing your costs down, but bringing your revenue up by not using a PTA. But in most models, home health, facility-based stuff where it makes sense, the pitfall that I've seen is it's really just like operational model where it's all in or all out. We use PTAs, we don't use PTAs. We use COTAs, we don't use COTAs. And in those models, it is literally like I do the eval and I will see them again, even though the law is, at least the 10th visit, particularly just like SNFs, 21 days and all the fun stuff, home health. I will magically see them on the 10th visit. I would say even if there was a concern from the PTA earlier than that, the likelihood of us texting about it may be high, assuming that we're using secure text. But the likelihood of someone doing something about it's low because there wasn't a scheduling operational pattern of saying, should this patient not be stable and the care plan looks like it needs to be adjusted frequently, then I should be contacting this patient earlier. And what I would say to the end of this is it's really about the right provider at the right time, which is upon that evaluation, on my care plans, I usually put something like the patient's appropriate to be followed by a PTA, and I kind of write a little statement. But I probably sign that in every single document. And the reality should be there are some patients who are so unstable and unpredictable in the beginning that really what's the harm of going I'm going to hold on to this patient for 4 visits to make sure that they're stable enough to a point where I'm like, you know what? I now believe that it's still skilled care, but it's predictable skilled care. I can write up a care plan that can be modified and adjusted so it falls in the bounds of I'll write up a care plan that's going to be adjustable and fluctuating based on the progress that I'm expecting. And instead of only waiting till an escalation of that 10th visit or whatever laws that I'm following that makes me see them, there should be a mantra of the right person at the right time, but that means that the care plan needs to be steered to be the right person at the right time which is hard to operationalize when every single patient I see, I don't know if I need to see them 3 or 4 times, 2 or 3 times, or once every 10th visit, but that's probably the way that it should be.
I think it's like anything else where by design, the PTA, COTA are supposed to be the extension of care services. So by design, the PT and OT writes up the plan of care, and then the execution is done by well-trained clinician who is an extension of service. So then they deliver this type of care. So then the PT does the triage, the screening for red flags, and identifies opportunities for the optimal care delivery. And then the care delivery occurs from the PTA, OTA, right? The reality, though, is that I have met some really brilliant PTAs and COTAs that probably pound for pound are exponentially more valuable to the clinical community than any PT. And so the question here is that the level of autonomy and the level of agency that the PTAs experience and the COTA experience is determined and defined by each organization rather than having some kind of a global appreciation and understanding. So based on setting, based on platform, right? You have a PTA that's going to be taken on just a majority of responsibility, and then PT just signs off in the notes. Or you have settings which really, I think, do a really good job operationalizing it, where they would have a ratio of PT to PTA, where a PT has a core responsibility of onboarding patients and screening. A PTA has core responsibility of care delivery, and then there's documented pacing for when this occurs, whether it's 10th visit or 8th visit, in order to be in compliance, but also in order to provide best care. I think that is the gist. And I think if, as we continue to have this conversation, we can explore how this discipline, this wonderful discipline, can be leveraged to optimize care delivery.
Something that you said reminded me of something that in nursing that I've been told is a challenge for hospitals. And I'm thinking there may be a parallel here. So let me know what you think, guys. So in some hospitals that are looking for magnet designation, are you guys familiar with that term? Magnet designation has to do with the quality of their nursing care. It designates a hospital as very high quality nursing. And one of the requirements for that is, I believe it's 80% of the RNs have to be BSNs. And so the challenge that I'm hearing about that requirement when I was working in the health system was that BSNs have a short lifespan where they actually want to work in bedside acute care. And then they're off to doing other things once they get experience. They want to like move up the ranks. They want to work in quality, right? And we know a lot of the jobs in the hospital are often suited for or named for nurses. But if you want to be a magnet hospital, you have to constantly keep that 80% BSN ratio to associate degree nurses or ADNs. It's a challenge. And the other challenge that they express is that the ADN nurses, I know generalizing, but they tend to be satisfied with a longer term career in bedside nursing. So I have little experience with working with assistants directly. So I was wondering what your guys' thoughts were about that.
I'd actually say it's the opposite. I've found that there is, for just a ratio of what I've experienced of PTs versus PTAs, when we talk about wanting ambition towards management and a higher level. I mean, just going through my head now, thinking about all the times that a managerial position was actually held by a PTA or even a COTA,
Really?
like a significant amount, which created its own funny, there's some therapists like, I can't work under a PTA who's my supervisor. And it's like, you need to dissect the difference between a supervisor and a clinical license distinction. But I don't know. I don't know that I think that tends to hold true. I think there's definitely PTs who get to a point where they're like, I really kind of over the day-to-day clinical care, but PTAs also tend to get there, and then they're like, well, what can I do next? And I think the travesty answer would be, we're going to bridge everyone to a PT, because it's like the ROI for what they've done, a 2-year degree, which is not an easy course. I mean, I've worked with some of the PTA programs in the Palm Beaches, and I'm always impressed by the curriculum. It's 2 years, not much different than what the master's degrees were way back when, other than you're stripping out a lot of the diagnosis component, but it's a pretty intensive course load, and not cheap in a lot of places. Like there's some obviously like PT degrees in different parts of the country. Some are more expensive than others. But to say that the answer to your itch of doing more is you need to now go get your DPT, I think would be a shame. And I think it'd be a shame to also tweak their degree where like they have to do a little bit more to get more designation. Because when it comes to like salaries, I mean, I've got PTAs who work for me in a home setting doing outpatient care, and they could be making $80 to $100,000 a year easily. And it's like, how much more are you going to make with your PT degree? Especially what if you don't go into that setting and you go into a standard outpatient clinic owned by a chain? Like, you've capped yourself out for the amount of money, time, effort, and energy you're going to put in and non-earning potential during those years. I think that they are uniquely situated for success, especially if you're looking at where our profession's going. The fact that they wrote into law that a PTA can now be under general supervision regardless of the setting. There were You essentially needed a facility license to have a PTA under general supervision, whether that's home health, SNF, rehab agency, CORF. Uh, with those days being over, I think it's saying we trust the PTA more. There's more opportunity in different care models, like you take digital health. I think in digital health, it's just such a nice, obvious way to do it is PT doing the evaluation, PTA monitoring the patient's progress on the care plan, escalating up to the PT to then make a decision, PRN of how the patient's doing based on care pathways. And the only thing that kind of gets in the way of that working really nicely is this ambiguous question of staffing ratios depending on the state. Like you take a state like California, if I remember correctly, the State Practice Act is a 2-to-1 ratio of a PT to PTA, which is, I think, the lowest in the country. New York might be lower, but I want,
That's low.
and it's low. But then you get to, what does that even mean? Is It's like in certain settings, if I'm in a hospital, like that makes sense. Like there's two PTAs standing right there, they're working full time. But like if you take digital health, where I give someone a caseload of 500 patients to monitor, and they do 8 hours a week, and I give someone else 12 hours a week, and this person 5 hours a week, and this person 20. Like, how is it different that I can only supervise two versus if the tools are there for them to have actionable insight in how to manage these patients, and the tools are there for them to escalate to me in a live manner? Like, where does this arbitrary number of two come from, other than back in the day when it was like in a clinic setting? It was like Ben standing here on a pulpit, and we don't want 5 PTAs running around like crazy in a clinic while Ben's looking there, like just looking from down and saying, here's what to do. So I think there's probably work to be done on the Practice Act to make it where everything we're saying is ubiquitous across the country. But I think the profession as a whole is in a really nice spot, and if anything, getting into a nicer spot. And I think to answer a question that you kind of snuck in there, which is, what's the career opportunity if they get sick of clinical care? Management within the healthcare profession, like of just physical therapy, I think is very reasonable. And a lot of the large chains, promote it and are fine with it. But I also think that there's the skill set of having that clinical background, but being in an operational efficiency kind of program. I've seen plenty go on to get MBAs, which is probably a better use of time and money, is a tack on an MBA or project scene in the digital health space. Like some really nice leveraging into quote unquote non-clinical careers that are usually clinical, just meaning not maybe patient facing, patient touching. And I've seen PTAs really excelling there in COTAs as well.
Yeah, I think that the most important dichotomy here to dissect is experience versus expertise. And so one is horizontal and one is vertical. And so when we're creating someone who just is freshly minted out of PT school with a DPT, right, that the experience is lacking, but the expertise potentially there is that depth of knowledge based on the curriculum. You would hope that someone who's graduated a 3-year graduate program will have expertise to be able to evaluate some of the more complex cases. But that does not substitute experience for an experienced clinician who has seen and been able to manage a certain level of complexity. That experience is priceless, especially when it comes to effective management of patients, effective operational management. And so that's another point of the digital health. I think we're definitely facing a risk of antiquity, like many other laws, or like if you look at our taxation laws, that are some are carried over from like 1800s, and you have to have APTA stay on top of some of these emergent clinical care models that really do need to be updated, where you can have 10 PTAs or 15 PTAs still reporting into this well-structured digitized system that helps you manage a larger cohort, right? With some of these digital platforms that are supposedly covering 50 million lives, right? If you look at the ratios, they have like one licensed PT covers 10,000 lives, right? That's a healthy ratio. So one for 10,000. Unless you have a brilliant algorithm that really supervises it, like it's impossible to create any care complexity unless you start to use PTAs in this setting, where the PTAs are able to manage and document and control some of these digital levers, and screen for this lack of engagement, lack of compliance, which then can be escalated further. So again, that experience versus expertise, it really is we're creating a optimal system where with a licensed PT is able to onboard an individual into the system. So the system entry is by a licensed clinician, and then whoever supervises it through the different iterations within that system can be a PTA with the different step points.
Let me ask both of you this, because you threw out a number, you know, 8, 10, whatever. I mean, I assume that you've been inside platforms that are algorithmically, clinically dashboard, like a tab where it is floating the patients who need attention to the top, and you can manage scales of patients, because you're almost managing by exception. And I think you're probably familiar with the fact that like platforms like Luna or digital health, you know, they employ a lot of gig type workers where it's not the traditional where I just hired 3 FTEs. I can have 3 FTEs in staffing, but the 3 FTEs are actually made up of 11 people or 23 people. And my question that I would ask both of you is, should there actually be a number ratio of PT to PTA, or should it just be written in a manner where it's like, so long as the PT can adequately cover escalation and discussion and, you know, communication with their counterparts, like I would actually be shy to put in a number. I'm just curious what you guys think. Is there a number, or do you make the law to be vague enough that just says so long as you're adequately, and then the burden's on them to show that I can adequately handle how many?
I've done a little bit of work in my B2 job on scope of practice for like physician assistants, and especially looking at the ratio of physicians to physician assistants. It's the medical association that's the big barrier, and the strength of lobby that's preventing things like physician assistants and nurse practitioners from having full scope. It very much depends on the state. But they're under different associations, right? Like the physician or physician associate assistants, they have their own association, but the APTA covers both PTs
Right.
and PTAs. So who's fighting? I don't know the answer to this. I haven't thought about it for our own profession, but who's fighting the ratio in a place like California? Do you guys, is it the California Physical Therapy Association? I don't
I
know.
know in
No.
Nevada, the answer is yes.
It
Like,
is.
I mean, if you want to read some stories about Nevada's PT Association, hopefully this doesn't trigger anything on any snippets you pull out of it. I believe it is the association in that state. California, I just haven't heard anecdotally or even firsthand, which I actually chat GPT while we were talking. It is 2. It's the number is 2 in California. I don't know where that's coming from. It'd be interesting to know where is that coming from.
So the question too is, where is it coming from? Who sets the policy reflecting on what, right? But going deeper into this, if we as an industry are facing a significant attrition of experienced workforce, and we're facing a 30,000 full-time employee shortfall by 2035. That was the APT, right? The APTA freshly minted a paper from like a month ago that we are like the future economic workforce pressures for our industry. Wouldn't it make sense that if you look into that, just the threshold of what it takes to mint a PTA versus a PT, it's at best PT is a 6.5 year roadmap versus PTA, which is a 2 to 4 year roadmap. Wouldn't it make sense to change the forecast into a higher level of PTAs taken on the field, with PTs assuming a different roles within the industry? Again, based on a system entry. And to go deeper into the digital health question, Dan, it depends on a specific platform. So if you have a digital health platform that has been designed to stratify risk and to answer this diagnostic triage question, you definitely can have a higher level of complexity being managed by the algorithm. In my experience, there are few digital health platforms that are optimal in this diagnostic clinical stratification and triage. Most are more skilled in access and experience, right? So there's it's just a matter of can a PTA manage multiple levels of patient feedback and exercise compliance, right? Or what's the other point of this digital health solution?
I mean, in my head, I'm just echoing, like hearing two things that you each said, and one was talking about how you're insinuating that the AMA is fighting like the PAs and the NPs from like,
They
getting
are.
more and more and more autonomy. But two, and then you parallel that with like PTAs, who I don't think there's a huge fight in autonomy in the sense, like I said, major law passed that allowed for general supervision is about. I mean, that's probably more major than anything that's happened in the PT world as far as like specific to PT, even though PTA is like I said, it's association, same profession. Right. Yeah. So the question is like, all in all, though, we know that we have a staffing shortage across all of healthcare. I don't think there's any health profession that I've read is not facing staffing shortages currently and not expected to face worse and worse staffing shortages over the next 10 years. So you just think that why aren't all pushing towards like if there is a cost effective, time effective crop of students we can get into the system who have a much better, as I said, frankly, a much better ROI than their counterparts as far as making it worthwhile for them to go to school. You know, it's interesting to hear when you're saying that the AMA is likely pushing back on it. And then it's like, well, then who would be pushing back on it from our side? And I think it's probably not an association as I'm thinking about it. There's probably just some archaic state laws that were just put in. There weren't no PTAs in those states when the law was written. It's not easy to change a law. Sometimes it was almost a miracle that anything gets passed and just think that we're going to like, okay, let's reopen that and revote on it. Because what they don't realize is that law doesn't contain just a law about a practice act of 2-to-1 ratio that's tucked into some law that probably also had to do with like food stamps and this. And like, there's so much in a law that can go through. But if you want to change it, like sometimes it's a matter of, and it's not like you revote on an entire law every time, just opening up the can of worms that tucked everything into one law, I think is just maybe why some of these places have had it. So it's easier to pass a superseding new regulation to say, based on this and this and this and this, and just put it into the Practice Act somehow versus trying to change like state laws. But again, I'm probably also talking outside of my entire scope of knowledge and probably closer to your scope of knowledge.
No, I think that this is just such a great topic for us to uncover a little bit because there are some actionable steps listeners can take to better understand if this is a frustration for you in your own state to our listeners. So, the state work is so different from federal work. Federal, if you have to change something in statute that Congress has to address, it could take years for the right opening to come in the right piece of legislation that you can tuck something into. But when it comes to work at the state level, if you put in a concerted effort on the ground and work with stakeholders, it can be 1 to 2 cycles where you can get a change. For each different law related to healthcare, it depends on the state, whether it's something that their Congress has to pass or change, or if it's a regulatory issue and like the state Department of Health addresses it or the state board. Is it something that can be regulated and that is handled by the administration? So like the agencies, or is it something that has to actually go through Congress and just takes longer, but not like federal law? You have to wait through cycles. Some states have a couple of cycles a year, some have one, and you have a window. And in the meantime, you're trying to build consensus. You're trying to find someone to sponsor if it's a bill. So the APTA represents all of us, including assistants. I'm curious and now have to do some exploration at the state level. Why do we have these arbitrary ratios when we shouldn't be fighting our own profession, right?
There's a lot of APTA wins right now, but most of them are at a state level. The Utah Physical Therapy Association
Right.
just did some things, and this association did some, which maybe makes sense why we could see some change relatively quick at the state level. Even the state laws are being passed for telehealth parity and telehealth access.
AI
We're
also.
much quicker on a state level. I mean, much like within days, those are passed into law, like on a state level, where the feds still are punting it down the road. Now till September, and who knows after that. But I guess that it helps explain why we don't see it at a federal level. and we see all these series of small wins at a state level, would make sense that it's just easier to get things done at a state level than it probably is at a federal level.
It's so much easier. And then what happens is when states start to take up an issue, if it's a big issue that the federal government wants to have a say over, they can at times feel pressured to speed up their process of legislating around a certain topic because otherwise the states are going to do their own thing and you end up with like disparate rules all across the country versus setting a standard at the federal level, which is happening in AI. Way out of scope for this conversation, but we're starting to see states act on issues around artificial intelligence and establishing guardrails, and the federal government hasn't gotten there. So you're not hearing a lot about that yet at the federal level because there's so many other big things being discussed. And that's just the thing, right? You can take an issue, find partners, build a coalition, and get something done in a year or two in the states. It's very difficult to do the same at a federal level unless it's really timed well. You can have to build coalitions and, bring in large organizations and take years before something can actually be legislated upon.
Hey, let me ask you a tangent that's not related to PTAs or COTAs, but it's really right up what you're discussing. And maybe you cut me here and patch us into another discussion. Why then wouldn't it make sense to standardize the practice acts of all states, and which would then make it where we don't need compacts? You have one professional healthcare license and it goes across all states and districts and territories. Wouldn't that just make sense to standardize it so that then you could affect change from a state level to a federal level? Because if everyone's behaving some way at states, then the feds at some point, to your point, are going to have to say, well, 32 states have adopted this. Maybe we'll do it. But my point is, if all states act the same for all healthcare license, physicians are licensed in one state, but their license reciprocal in all states kind of thing. What do you really sense is the barrier to stopping our licenses being more national than they are state?
Political willpower. There's so many other priorities. You would need to have sponsors on one of the committees of jurisdiction over healthcare. So you need sponsors for a bill in both the House and the Senate. You have to come to a consensus. It's a major process, and there has to be willpower. They have to really want to do it. And when you're looking for sponsors for something, you're thinking about, well, what's the priority for my profession? That's not going to rise to the top. You're going to try to pick away at something that's a really big problem, tangible problem for the profession. This is why I kind of get on soapboxes a little bit online about us worrying so much about the conversion factor fix when we have physicians dealing with physicians and physician specialists who are going to benefit much more from a fix than we are. They're dumping loads of money into advocacy. So why are we bothering with that rather than working with CMS on things like increasing the weight of our codes, having us be seen as providers or practitioners, right? Like adding additional codes for coordination. Like those are, to me, much more tangible steps that we can take and leave some of this, that covers all professions, leave it up to the specialists and the AMA to handle.
Again, we're totally going off the rails, and I agree. Where it's like you said, why can't we even just get a code for education of a patient, which is one of the most skilled things we could possibly do? There's no payment for it, but the effort we'd spend into getting our 2% cut reversed, A, it's not going to happen. And B, if it is going to happen, it's going to happen because the AMA has done something. Why can't we spend the time fighting on things that are incremental changes that are pushing the profession closer to where I assume, where we all think we want to?
Do you think it's more of a definition of sunk cost, where we've been fighting this fight for so long we forgot why we started fighting in the first place? You just continue on a mission.
I really don't think it's a sunk cost thing.
It's something that is the constituents that they're members of the APTA. It's what they're very focused on. I think associations all across the board should be doing more to galvanize their community to understand what changes they need to evolve and get their support. Who else has the voice except our association?
And is APTA really the association that is looking after our governance, right? Long term, like should they have that responsibility, or should that responsibility, again, to go to the prior conversation, fall to the states, and then there should be a consortium of states that derive to these conclusions, which is already the case, right, in some accounts.
And there's some groups in between that are lobbying that, aren't APTA, but are either spin-off derivatives or closely related.
Yeah. Yeah, I think if you look into the APTA, like the mission is historically always been about access to care, population health, and supporting PT-based research, right? And so the research pipeline has been as healthy as ever as far as access and accessibility to care. There's certainly not a shortage of care providers, and then the population health, we're still here. I think that's the fundamental truth of like episode 1 from Dana, where PTs are the best kept secret. We're just no. I think it's a comfortable truth that as long as no one knows that we are cheap, efficient, and do a good job, then everybody wins except for us. So how do we exercise that freedom and get a higher voltage of awareness in a community?
You're probably not paying as much attention as I am to things that are being said on the Hill, but there is an interest in this administration to disrupt the ruck, and that could look a whole bunch of different ways. But therapists should understand that these things are being talked about. If the ruck is disrupted, and there are different ways that we decide the weights and the values of different services, including ours, right? Ours are included in all of the services that are weighted by the ruck. The ruck advises CMS on how much they should pay for every service and what weight it should be across all professions, right? If that's disrupted, are we ready to go in and say, here's how we think our services should be weighted in an advanced primary care focused environment? Because the reason for disruption, a lot of folks feel, is that medical specialists have a much higher reimbursement and a value to their codes than primary care. We have been bucketed as specialists. And 2 years ago, when we got a 3% cut, it's because we are not seen as that primary care bucket.
We don't have EM codes, and
No, we don't have any EMM codes, but we don't want to be viewed that, in my mind, that way, because it puts us at risk of being cut. We're not first to the patient in the minds of policymakers, which is why this direct access we needed it. But it doesn't mean that the federal government is viewing us differently or updating regulations and annual rulemaking to give us more weight to our codes to drive us as practitioners, right? So I know this is layered, but I think it's something therapists should be paying attention to. If they decide to reimagine how we decide how much we pay different providers for different services, I want us to be ready. We're not even called practitioners. We're not in that bucket with dietitians and clinical psychologists and LCSWs. We're literally not in that bucket.
but we also have to be because I've worked alongside the chiropractic profession for 9 of my years. And I saw what happens if you get in limbo also, which is worse. Worse is what they were able to advocate and be called what they want to be called and kind of get designated there, but then they're stuck where they're not actually given all the affordability of being a physician. So like what would be, in my mind, almost worst case scenario is that we do something, we get halfway there, we end up in some of this like hybrid bucket, but yet we don't have all the affordability of everything that we wanted to gain. Care management codes, E&M codes.
But give us what behavioral health has made a path. They have advocated very well to be viewed differently. They're not physicians, right? Only physicians are physicians. But to at least to be called practitioners, which all the behavioral health specialists are and dietitians are, right? For us to be practitioners, then, right, it at least puts us on a little bit more even playing field with some of those others who are part of the advanced primary care group. If we could be bucketed in the practitioner group, which we should be, right, that puts us in the bucket of advanced primary care providers. And if we're going to reevaluate the weight of codes as designated by something like the RUC, then we should have a better place in the advanced primary care centered payment models. Am I resonating with you guys? Does that make sense?
You're almost bringing it full circle. Here we are, one of the few professions who have schooled and licensed therapist assistants, physical therapist assistants, I believe is a term, not physical therapy. We actually, there's not a lot of practitioners who have the equivalent of a PTA or COTA. That our profession is so complex that we've allowed this adjunct spec. So, to have this assistant profession as a licensed, have to go to school, have to get a degree, have to pass boards, or they have a state like we have that. Does a dietitian have that? Does a mental health provider have, like, our profession is so complex that we have that, yet we can't get ourselves over the hurdle to the level of being a practitioner.
We have to
So
prioritize
I
it.
think that's actually a
Like, if you look at some of the archaic stuff, that's been loosened. Like I said, there are some wins, but that a physician has to sign our plan of care for Medicare. I mean, it really is crazy if you think about it. The physician has to sign off. They gave me a prescription, and now they still have to sign off on a plan of care of something that I haven't agreed, and being able to make this plan of care, and I'm abiding by state and federal rules for this.
I agree. It's silly, but what we need
No,
to
no, no, what
win
I'm
on
saying
is
is it just
practitioner.
shows you, I think, to
I know.
talk about the genesis of how we got stuck in this
Yes,
bucket. It really was this, like, it was almost like we work under the physician
that's right.
concept. Probably is how the profession, I'd have to go back to, like, my history books to get a refresher on how the profession. I mean, I know it started, like, really in earnest with polio, but, like, why we're stuck there may have been because of how the profession really started versus how the profession has evolved.
so from the bucket of recency bias, because I just heard this episode on Freakonomics podcast. Richard Thaler was a guest on the last two episodes, and they were talking about the sludge, like, so nudge versus sludge. And in terms of economics, the nudges are the behavioral shortcuts, and then the sludges are purposeful friction points that are placed to reduce the rate of consumption. To, like, they're essentially there to have a purpose of reducing the likelihood of you utilizing care. So a lot of these rules and a lot of these constraints are there for a reason, to create a friction point so that the rate of consumption is not going to be a runaway process.
I have the reference in Code of Federal Register where they define provider and define practitioner, and this is where they go through all the different mental health professionals and dietitian that all are considered practitioners. This would be a matter of, working on that as an issue and saying, look, foundationally, we are not practitioners, and this is the beginning of a set of problems. We have to back up to that issue and then build from there. That's not that hard of an issue to tackle, right? I mean, dietitians are practitioners, right? Social workers, practitioners. We should be able to get that win. And I would argue it's a critical win. OTs too, right? We belong in that bucket. And because we're not, we aren't viewed the same. You have to build from there.
And even if we are viewed the same or not viewed the same, we aren't provided the same rights, essentially. Like, we're held out of conversations that when another law is updated and they now
That's
say
it.
refer to practitioners, we're immediately now excluded from that next law. And then the next law that goes to clarify that and give it more rights and regulations and whatever, we're still not, now we're two laws behind. And so, yeah, and again, that to everything we're saying, that might be something that's a true win that our lobbying groups can do versus saying, like, we're going to, have you and every patient write a letter to your congressman about the 3% cut. I think that's being tackled by other people, and B, is our energy spent better in other places. One thing, Alex, I just want to say though, in a lot of medicine, I think what you said is true, that there has to be friction points or else consumption can get to low value care. The part that I just fundamentally disagree with is I don't know that there's much low value therapy care, even if it is low value therapy care. Like someone just doing 20 visits of garbage heat and stim, the downstream savings, even by, like, early access to that care or delaying a visit to an orthopedist, like, I don't know that there's any reason to have that sludge, as you said, as that sticky point to delay care. Like, they're so in the scheme of the larger health system. I don't know that physical therapy will ever hit a line on a P&L, even if you got rid of that sludge, that it's going to start going, oh my gosh, boy, are these guys killing us on our budget. I do
No, it's
believe
how we're
that,
perceived only. You're right.
yes.
It's just a perception issue. All healthcare professionals outside of physicians and APPs make up altogether, everyone combined make up 3% of total spend. We're a fraction of that 3%. So it's not that we're blowing up spending. It's that if we don't provide high value care, we're not going to be seen as up at that practitioner level. We're going to be seen as somebody who fills prescriptions, to one of Alex and my conversations. We don't want to be someone who fills prescriptions. We want to be elevated, and there shouldn't be barriers to therapy because it is such high value care. We want to be giving the right care at the right time, but we're not blowing the budget up. It's that where we're perceived is someone who fills prescriptions at the policymaker level. I'm generalizing, but like we have to generalize to make a decision to make change.
I mean, you just said a statement that hopefully you clip and put a graphic behind, where you said we have to make a decision to want to make change. Like, I think that needs to be the concerted thing, and then you need to take an approach of like, is it small wins? Is it going to root of things? I think there needs to be this. I think as a professional, I'll feel better if we see all these, even if they're small wins, but small wins. But to your point, the biggest win we need to do is anything we can do to make it that we're more in line with direct access primary care type behavior is the win, much more so than fighting over things that are either beyond our control or minutia. Looking back on history will be minutia compared to what we can do.
Yeah. So just on the top of your mind, can you name some of the biggest victories for our professional last decade? What have we won? We win these nominal things.
I would actually say that general supervision is actually probably a pretty big historical event. I don't know that like, I'm probably standing on a island when I say that, but the
It was a big
ramification of
one.
it I think is actually pretty huge.
And besides the general supervision, which I agree, like what else have we won? Because we continue to push for change, but we really like there hasn't been that much change to begin
The
with,
federal
at least
level,
from
I
my
can't think
view,
of
right?
anything.
Yeah,
And even
like
at a state level, a lot of these direct access things that we applaud, and again, they deserve applauding. I'm happy and I want it. If you ever read anything I write, I kind of have like three things, and one is actual direct access. One has to do with credentialing. I believe in a much simpler, better credentialing process. But direct access can't be direct access in name only. And in many states, it still is direct access in name only. And it's frustrating to know that we have not won that at a state level, as far as I'm concerned, let alone a federal.
For sure. And I think in the states which really have a true direct access, they still only have a fractional utilization of it. So like then who's the culprit and who's the fool when you have states with a lot of autonomy that the clinicians that don't embrace it because we continue to exercise that the more we capture the experience instead of exercising this newly found source of freedom, right? I think the problem, if you want to summarize it, probably it's twofold. There really is a problem in perception and policy. There's also a problem within the industry of both lack of awareness and lack of execution. So we are still sitting on a point where really are petitioning a congressman about the rate cuts that is unlikely to impact us significantly, but we don't have a much greater awareness and knowledge of some of these larger global changes that need to occur. So hopefully, I mean, that's the value of this type of medium is to educate the educator. So
Where
our
you're
voices, right?
Even where you're pointing that tool, like take a rate cut. Again, I have healthcare businesses. I don't like the rate cut. Okay. But if I'm going to fight over something, I'm going to fight over MPPR because the likelihood of actually changing MPPR is realistic. I'm not saying easy, and I'm not saying it's going to happen, but there's a path to that. There is not a path to the PT profession changing the rate cut. Like there's just not a path. And I'm not trying to be cynical. I'm trying to be highly realistic and just saying, if we sharpen that point, great. Let's sharpen it and point it somewhere. Let's point at something that we could actually affect change, even if it is XYZ cycles, 2, 3 cycles of whatever. But from what I read, I believe it was the radiologists actually were able to conquer MPPR and say that it shouldn't exist and it can't exist, and they got it overturned for their profession.
Everyone's being paid for 2025 with that 3% cut. This is not the time to, expect there's going to be a good legislative vehicle to get that annual fix that we've been seeing happen year after
Getting rid
year.
of the 2% sequester and calling it a
Well,
day.
that too. I will say I'm grateful for a lot of the work the APTA has done. I have not done enough to participate in the APTA over the years. I know professional associations have to balance the interests of all kinds of different therapists, or whether it's physicians in their associations, or right. Everyone's got a lot on their plate. If I had my druthers, I would focus on things like, are we going to be practitioner? Can we be called practitioners? Can we lobby for different additional codes similar to what the behavioral health providers got for collaboration? These kinds of things I think are actionable and would make a material difference for the profession.
Like a true win that we could sit back on here and go, wow, that materially changed the profession.
Yeah.
I will look forward to that date.
Any other parting thoughts, Ben, after you spent 2 awesome hours, more than that, with us?
It was a good time. I appreciate you having me and not editing me out of the entire thing. That was very nice.
It was excellent.
If you get really bored,
You're welcome
I'll
back.
say that you're part of it. You really are a thought leader and just a absolute brilliant mind to have. It's been a terrific couple of hours.
It's a
Awesome,
gift we're
guys. Thank
giving
you.
to our listeners. Thank you, Ben, for being with us. Alex, as always, my awesome co-host. And we will see you all soon.
Bye.
Thanks for joining us today for episode 9 of the Future Proof PT podcast. If you enjoyed the episode, we'd love for you to share it with a friend, and please like and subscribe it if you are watching this on YouTube.